Hi, and welcome to Chapter 11. The video above showed you a quick anatomy review of the shoulder, and so I hope that you are aware of the complexities that occur both physiologically, but now also with some idea to the injury standpoint at the shoulder. This book does a really good job of making shoulder injury pretty much black and white, but I will tell you as a practicing clinician that there is a lot of complexity to the shoulder when it comes to injury, and we have to determine where that injury came from, and many times that comes from a very acute blunt force trauma type, well-described mechanism type injury, but many times it comes from things that are very hard to see, especially when you start talking about chronic injury. And there's some gray areas with the shoulder, and I'll kind of talk about that here in just a few moments. But just a quick anatomy review. You have three main bones that make up the shoulder. The clavicle, or your collarbone up here at the top, it's kind of an S-shaped curve to it in the middle. You have the scapula, which sits on the back of the rib cage, and then you have the humerus. The humerus has an interface with the scapula called the glenohumeral joint. The clavicle and the scapula come together at the acromioclavicular joint. And then the clavicle has a proximal attachment over here on the sternum and the sternoclavicular area. And your book talks about sternoclavicular injuries, and they're very common, but we don't see a lot of them in sports, but you can read more about that in your text. Where I would like to start today is with clavicle fractures. That's the first one on my list. And a clavicle fracture typically occurs not from a foosh or fall on an outstretched hand. It can occur that way, but a lot of times a clavicle fracture occurs because a person falls on the tip of the shoulder. And when they fall on the tip of the shoulder, what could happen is they could fracture the clavicle, and if they do, it's typically in the middle third of that area of that clavicle is where we find most fractures occurring. And so on your clinical exam, what you would do is you would use your two fingers and you would palpate down that clavicle. And if you do just a little bit of palpation down that clavicle and you're pushing like this, what you'll find is that they'll have a lot of pain. And typically people who break their clavicle tell you, I just broke my collarbone, because they know what has happened because of the sound, because of the feeling, because of the pain. And it is a very painful injury. I've never personally had one, but I know many people who have. So again, middle third, most common area for fracture. They're falling on the tip of that shoulder, or they're getting hit. Sometimes, but least commonly, is a foosh. Next on our list is dislocation and separation. And I want to bring these to the forefront together because these terms are sometimes presented synonymously in layman talk amongst people in athletics. And so what I want to do is I want to take this and I want to give it specificity and say that a dislocation happens at the GH or glenohumeral joint, which is right here where the humerus interfaces with the glenoid, remember, at the scapula. And then a separation happens at the AC joint, the acromioclavicular joint up here on top between the clavicle and the acromion. So those are two very definitive terms. And so if you use one term to a healthcare professional, then you need to mean what you say. So let's first talk about this dislocation. What happens with a dislocation typically, and it can occur from foosh, it can occur from falling on the tip of a shoulder, it can occur from having so much force when a person is throwing specifically a ball that they externally rotate too hard, and they can actually dislocate from that too. I've seen dislocations happen from a lot of different reasons, so don't be surprised when you see a shoulder dislocation. And typically when they happen, it's because a person has a laxity or an instability in their shoulder anyways. First-time dislocators, that's a little different story, but a lot of times you'll run into people who have chronic dislocations in the shoulder. And a shoulder can dislocate in three directions. First, it can come out in the front, and when it does, it comes out this way to the front side, and the back of the humerus literally lands on the front of the glenoid rim, and that's called an anterior dislocation. You can have a posterior dislocation, which is the exact opposite, where this humeral head comes back and it smacks against the posterior rim of the glenoid fossa. And then you can also have an inferior dislocation where it just comes out and lands at the bottom of the glenoid fossa. Either one of these is pretty traumatic because you have a ligament that lays around the humeral head called the labrum, and that typically is torn with a dislocation. Also, you have rotator cuff muscles, and we'll talk more about those here in just a second, but those all come out and attach, and so if you dislocate, typically you have a strain type injury to those rotator cuff muscles as well. So lots of trauma that is incurred, and a chronic dislocator is someone that typically needs surgery, a very specific surgery. If you dislocate once, a lot of doctors are not going to do a surgical procedure to repair that, but it depends on what doctor you see and what their preference and philosophy is. But a typical dislocation event requires a professional to intervene to reduce. And so what I'm saying there is, as a coach, I would not recommend you going out and trying to put that shoulder back in. It's a very painful thing for a patient to go through anyways, and so if you can get them off the field or off the court and into a emergency department, that's the very best place to put them. Next on our list is a separation. Separations come mostly from that landing on that tip of the shoulder, and when that happens, this joint right here has 3 ligaments that correspond around it, and what happens is they sprain. And so a separation is literally just a sprain in most cases. Now, your book talks about 6 different grades or degrees, of AC separation. And the first couple are pretty easy to deal with. There's not a lot of displacement of the clavicle here. And what they're saying is that this clavicle will typically displace upward like this right here. I have known many people who have had these injuries, and that clavicle does come up. And typically, unless it's a grade 3, they don't repair, especially if there's no abnormal or lifting of the clavicle. So what we know is that if that clavicle is stable, they're just going to rehab it and let it go. But if that clavicle is up and abnormal in appearance, that may need to be repaired. And so what they do is they go in and they suture that back down in some way or another. What I do want you to think about here is, if you see a AC sprain, how do I tell that it's an AC separation or sprain as opposed to a clavicle fracture? Well, remember when I talked about clavicle fractures, I said most of the time that pain is here in the middle third. If it's an AC sprain, they're going to have pain right over that joint, and you can palpate these joints pretty easy. If you would, while we're watching this video, just take and follow your clavicle down from your sternum all the way around. You'll make the S curve, you'll feel that middle third, and you'll come to an area that's kind of lumpy, and that lumpy area is literally the joint. And so if they have pain in that area, and you can identify the mechanism as a fall on a tip of a shoulder, but their pain is all distal and they don't have a big lifted up clavicle, then they probably have a pretty simple, common grade 1 or 2 AC separation. It's sometimes important for us to send those in to be evaluated by the orthopedic doctor, though, if you see the least little bit of elevation out of that clavicle. Next on our list is rotator cuff injury, and I put here rotator cuff tear, but again, rotator cuff is a series of muscles that literally surround the humeral head from the scapula, and they are involved in rotation of the shoulder, but also they're involved in abduction of the shoulder. And so what we know is that rotator cuff tears are common in overhead throwing sports, but they're also common in older adult populations, from people who are not active at all, and they just do something kind of silly and they tear the rotator cuff. Sometimes we've seen rotator cuff tears occur just because a person hasn't been active and they do one little simple thing and they tear the rotator cuff later in life. So rotator cuff tears are pretty complex in the way we have to treat them. Most of the time they're surgical, and most of the time they require substantial time off. If they occur in the younger athlete, how do I really know that that's what it is? Well, they're going to have shoulder pain. They're going to have gross shoulder pain, that they know something has popped, that they have no real deformity like you would in a dislocation or a separation, but something has popped in their shoulder. And so the typical test that I do is I take their arm and I see, first of all, if they can actively abduct their arm. So that's just coming out to the side. Most of them are not going to do that. And if they can't do that, then that's a muscle injury, and typically it's a rotator cuff injury, and I want to get them checked out by an orthopedic doctor. The next thing is you can actually test the rotator cuff by taking that arm, abducting it, turning the thumb down, and putting it just a little bit forward like this right here, and pushing down on it, and having them resist that. That's called a Jobs or an empty can test. I've linked a video down below so you can see that test live. That's the most commonly used test to assess for a rotator cuff tear. It's something that you might become proficient in, especially if you're working with older adults, but also if you're working with baseball or softball or any overhead throwing athlete. The next thing on our list is brachial plexus injury. And again, this is something that could happen from a FOOSH, but typically it's something that happens from a fall on the tip of a shoulder. And this is not necessarily a shoulder injury as much as it is a neck injury. The brachial plexus is a neurovascular bundle, which means nerves and blood vessels coming out of the neck, specifically from C5 to T1. And I'm naming the vertebral segments that comes out of from the spinal cord. And when it comes out, it goes under the arm and down the arm, and it becomes it's all peripheral nerve, but it all dissipates into different nerves. And what we know happens is when a person falls on that shoulder, their neck gets kind of pushed to the side. So we'll talk about my right shoulder here getting pushed down, my neck getting pushed to the side, stretching that neurovascular bundle and causing both numbness and muscle weakness in that affected arm. You can also get this from falling, hitting your shoulder, and it really not hitting your shoulder as much, but hitting your neck and compressing the contralateral side. That's the same kind of injury, and typically much worse because it's a compression, where that distraction side is typically something that heals up a little faster. You've seen these probably before. We refer to these a lot of times as burners or stingers because of the way it makes a person's arm feel, but the weakness is really what matters. What I would ask you is, do you want to go play football with one arm? And the answer would probably be unanimously no. I would not want to go play football with one arm. But that's literally what we send people back in to do if we return them and they don't have good strength. So if you encounter a burner or a stinger, what you need to do is you need to muscle test them. And what I have below too is a video showing muscle testing for the brachial plexus. And it's a very simple thing that you can do on the sidelines to evaluate whether a person is able to return to play after having that brachial plexus injury. I would always say that err on the side of caution. Don't send them back in if you suspect that they're not strong. But definitely, if they can't do these tests, then you need to hold them out. Last thing on my list is impingement syndrome, and it's marked in red because this is one of our chronic injuries that we see in the shoulder. And impingement syndrome is unique because we see this most commonly with overhead throwing athletes. It's an overuse injury. They've thrown a lot or they're doing something over their head. It doesn't necessarily mean that they're an overhead throwing athlete to get this, but they have shoulder pain that's diffuse and idiopathic. They really don't know why it has occurred. But they know that when they try to repeat that overhead motion, that it hurts. Anytime they get their arm up, it hurts. And that is because what we are doing is we are irritating three big tissues that come between this acromion on the bottom side right here and the top of the humerus. And so those three tissues are biceps tendon, which comes up off the biceps and around and inserts on the glenoid and the coracoid. The next one is the rotator cuff as it comes through from the scapula onto the humerus. And then the fourth one is the subacromial bursa, which sits just underneath that bursa. And so these three tissues have become inflamed, and now what we're doing is we're compressing them by abducting and typically crossing the shoulder and compressing every one of those tissues between the humerus and the acromion. So what we do is we look at this by saying, okay, it hurts to go overhead. You don't know what you've done. You haven't landed on your shoulder. You haven't fooshed on your shoulder. So we think that this is probably chronic, and it could be other things, but typically this is what it is. And what I do is I'll take that person, I'll lift their shoulder, and then I will abduct or adduct them across their body and I'll see if that kind of hurts them. And that's also a test that I do for the AC joint. So if there's pain there, what I want to do is I want to give some differentiation between the AC joint, and then say, okay, what I'll do is I'll internally rotate that shoulder across their body like this, and if that gives them pain as well, then typically I'm starting to think that it's an impingement syndrome. But it all really comes down to their mechanism. How did they do it? I know this has been a longer video. I appreciate your patience. Go down, take the quiz, watch the other videos on how to evaluate specific shoulder injuries, and I will see you in the next module. Hope everything's okay. Email me if not.